Tihe Maori ora, ina mana, ina reo, ina ho e wha, tēnā koutou, tēnā koutou, tēnā koutou katoa. Ko Ivona Stalark toku ingoa. A warm welcome to your online quality and safety workshop. I'm Ivona Stalark, I'm the Medical Director at the Health Quality and Safety Commission, and I'm going to be telling you a little bit about the work of the Commission. And my colleague, David Hughes, who's our clinical lead for our safety program, will be telling you a little bit more about adverse event program later on in another webinar. So who are we and what do we do? So our vision here, you can see, is quality health for all. And that puts people right at the center and at the heart of everything that we do. Our mission, which we've just updated here, tells you about how we work. So we work with people, we involve them in partnerships and strong relationships to gather intelligence, to help inform the sector and ourselves of what's happening, and to use this information either in frameworks or position statements or publications to influence. And sometimes we have some improvement programs, so we do some improvement work ourselves. This slide shows you our new statement of intent, which we've written for 2020 to 24. And our aim is really to improve the quality and safety and experience of healthcare for everyone using services. So when we've refreshed our statement of intent, we've looked at ourselves and we've decided that our enduring priorities and our foundation is going to be based on Te Tiriti o Waitangi. And as you can see there, we have taken the articles Kawanatanga, Tino Rangatiratanga, Orititanga, and the oral article Wairuatanga as our foundation on which we base all our work and which will endure. Over the years, our strategic priorities might change. And here are our strategic priorities for 2020 to 2024. It's improving the experience for consumers in whānau and putting them really at the center of quality. For us as an organization, it's about embedding and enacting Te Tiriti o Waitangi. And in terms of health outcomes, both access and outcomes, is about achieving health equity. We're looking also to strengthen our systems for high quality services. So these are our strategic priorities for the next 4 years. Now this slide shows you some of our current programs, and as just a few examples, our health quality intelligence team produces atlases, produces patient experience surveys, and once a year produces a Windows document that looks at New Zealand health and compares us with other international health systems. We have a strong consumer engagement program run by our Partners in Care team. We have mortality review committees who at a national level look and do a deep dive into deaths in certain areas to make national recommendations. And some of the committee work covers child youth, covers family violence, suicide, perioperative deaths, and also perinatal and maternal deaths. We have some improvement programs that you can see there. And one of our key programs is also our learning from adverse events. Now, when we think of adverse events, we also need to look at what do our users of health services tell us about the system. So I'm going to play a video now which highlights Rose's story of an adverse event.
I'd broken my femur in my leg, and then the best option seemed to be to give me a hip replacement because the blood vessels had been would be cut off, and so it would only be a temporary sort of move, a temporary sort of solution. And so that night, because it was very acute and obviously, you know, it wasn't a planned elective surgery or anything, they operated and gave me a hip replacement. Once I was back in the ward, I think I was still quite kind of traumatized because was just totally unexpected. And my daughter was in the city. She was the only person I knew at all, and so I was in a ward with 3 other women. I was heavily sedated, and still quite, really traumatised, I think. Attending to my medical needs didn't seem to be a problem at all. There were a lot of people constantly kind of rushing and moving, but I did get very good treatment for the medical side. The hip replacement went beautifully, etc. There were some medical complications, but I, as I said, only my daughter could visit me. So I felt very isolated, very vulnerable, very kind of very uncertain, very uncertain about my future too. But there was no one there to kind of give me any reassurance. The treatment was very much about medical matters. No one, I was there for 9 nights, and not one person actually asked me, how has this affected you? Are you okay? And I think that's what was really missing. There seemed to be a lot of staff coming and going, and as I said, I was very sedated, and I didn't remember people's names, and not everybody wore a name card. It would have been useful if people had reintroduced themselves or even worn a name card so that I had a sort of visual memory of, that I could associate with a person. So I didn't know even who was my main doctor, and I didn't know the occupations of a lot of the people who came. One thing that was really unsettling was 3 times I was told that I was going to be discharged, I suppose informally by, I think, 1 doctor, 2 nurses. I don't know what a formal discharge means or who gives it. But so my daughter came, she lived quite a long way out, from the city. She came twice, and suddenly, oh no, I wasn't going home today. But I wasn't given any reason, so I just wasn't being discharged. So it wasn't until the 3rd time I'd been told that I was finally discharged. I found that really upsetting. I felt frustrated that I couldn't get information quite often. That was one example. Why was I still there? When was I going to be able to get home? It was reported about day 6, I suppose, to someone whose job seemed to be to check on mental capacities of patients. And one of the hospital staff reported to that person that I seemed to have high anxiety levels. And so that senior person came to visit me, and I realised that was the first time anybody in the 9, including if I go forward a bit to the 9 nights I was there, it was the first time anybody had actually allowed me to talk about what had happened to me, and the sort of way I was feeling psychologically. And so when she talked about my high anxiety that had been reported, I said, yes, I agree with you. I'm not normally that kind of person, and I'm not used to being in hospital. This has been an incredible shock to me. But I don't think I'm solely responsible for what's happened to me. And I think that the hospital and the things that are lacking in terms of patient care have actually contributed to this so-called high anxiety state. The response to that was to send me off to do some psychometric tests to test my mental capacities, and I actually found that quite, I was quite affronted by that being the response. Again, no acknowledgement that if I was feeling anxious, partly that was, I thought, a natural response to the traumatic event that had had such an effect on my life and left me feeling very vulnerable and not knowing about my future. I was finally discharged, and I stayed with my daughter for a couple of nights while I organised for a flight back home to my home city. once I got home, I was fine for the first few days. Then I woke up one morning and felt quite feverish, and a friend was around visiting, and I showed her my wound site because it had kept me awake during the night, and she took one look at it and she said, "You need to get to the hospital. That looks like it's an infection under there because it's all inflamed." I was rushed straight into an isolation ward in the hospital in my home city, and spent the next 5 nights there. It was just such a completely different picture, different situation. I was immediately struck by the friendliness and warmth of the nursing staff, because I guess they were the first people I had contact with. There was a sense of humour when it was needed throughout my 5-night stay that really made a huge difference. They all used my name. I knew their names. They told me when they were next going to be on duty. They would come into my room. They'd actually make small talk. They were treating me as a whole person, not just looking after my physical needs. The physical needs were totally, well catered for, etc. But, they would sit on the end of the bed. They weren't rushing. I remember in the first hospital, people actually standing, waiting for me to finish a meal and looking at their watches. There wasn't that sense of rushing, and it was a whole different kind of philosophy, I think, about how to treat people when they're in hospitals, and about their psychological needs, not just their physical needs, and that should be part of the treatment. I had 2 surgeons looking after me, 2 orthopaedic surgeons. In fact, one of them didn't usually attend to cases like this. And as I was about to go into surgery, the same night as I recall again, because it was seen as urgent, he said to me, "I'm so sorry about what's happened to you. This is terrible. You've had such an awful experience." And I just felt, my God, somebody understands. Somebody actually has expressed some kind of empathy and recognised what's happened. And he said, "So I'm personally going to, make sure that you're okay and that this goes well." While I was in the ward too, one night I just felt really weepy. And the nurse who was on duty came in, and she saw my eyes were a bit sort of watery, and she said, "Come on, tell me about what's happened. Come on, what's going on?" And she had this lovely, they all did, she had this lovely technique. She said, right, she let me talk for a little bit, and I said, I have so many questions that haven't been answered. I'm just worried about my future. I'm worried about this ESBL. I'm worried about, will I be incapacitated? Will I be able to do the things I used to do? What effect is this really going to have on my quality of life? Because nobody had given me any indication about those things before. And she got me paper and a pen, and she said, "Come on, sit down." She drew a line down the middle, and she said, "Right, one side, here's the questions for the infectious diseases team who've been treating you. And this side over here's for the orthopaedic team." And I wrote out all my questions, and I suddenly felt, just even then, I just felt like this huge load had been removed. The next day, people from both of those teams came to see me. It was just amazing. It was just a completely different kind of situation. I was always kept informed about what was happening in the progress of diagnosing, first of all, because it took 5 nights in hospital to work, well, what is this? What exactly is this type of infection that's been in my hip? And draining it out, and then working out the treatment for it, etc. And I was always informed how far along the tracks they'd got, and just having information, I realised it just makes a huge difference. For me, there's a need to recognise that people in hospitals, patients in hospitals, lose a lot of themselves, particularly perhaps if they're not used to being in hospital, and there's been some sudden huge change in their circumstances. Somebody needs to be responsible, I think, for checking on the psychological well-being of a patient. And that was a huge difference I noticed between the two hospitals. Small talk, sense of humour, calling a patient, knowing a patient's first name, giving a patient a chance to ask questions. I think time is a big factor, actually, because sometimes it takes a while for these things to come out. But they're part of the treatment, and they should be part of the treatment. And so that, to me, was a huge difference between the two hospitals. It feels now as though I'm back to my normal life. You know, I haven't started yoga again because I'm still a bit anxious about that. But I never get any inkling of a problem with my hip replacement. I have a normal life.
Rose's story shows us that care can technically be very good, that's it's safe. However, if the experience is really poor, then we don't have quality services. Often when we think of adverse events, we think of the things that go wrong, maybe when someone's had the wrong procedure or some other big event that's happened. But when we ask users of health, they see this in very different ways. Last year, we spoke with Whanau Māori about their experiences of adverse events. They also saw adverse events in a very different way. What they reported to us was communication problems, not being involved or not being informed, not being heard when they had concerns, a lack of respect, a lack of cultural safety, with culture not being included or even considered. There were reports of unconscious bias and racism. Being Māori impacted on the care that you received, and you got different care than others. This report is going to be published later on in July. We've been gifted a title for this report, which will be coming out later in July, Ngā Tairo a Kupe. And this refers to the Kareao, the Supplejacks, the Tataramoa, the Brambles, the Tumatakuru, the speargrass, and the onga onga, the nettles, which are called the obstructions of Kupe. And these are the physical and mental difficulties or blockages. And this reflects the lack of cultural safety and when this is not observed, which was what the report highlighted. When we think about health and quality and safety, we also need to think about those who don't actually access healthcare, because the system doesn't make it easy for them. And this atlas summary, it comes from our Health Service Users Atlas. And I really encourage you to have a look at some of the other atlases that we produce. And this really illustrates from our patient experience survey that 15% of people report a time when they couldn't access healthcare from a GP or nurse. Often when we think about these people, we think that these are the elderly in our society. But actually, when we looked in a deeper dive, this was actually people aged 15 to 44. And this increased significantly when we looked at ethnicity. And this was reported predominantly by Māori and Pacifica. Those that had long-term conditions also reported difficulty accessing care. So this illustrates another aspect of quality and safety, access to care as well. So in order to improve the quality and safety of the services that we work in the system, we need to be working in the system and on the system, because currently it's perfectly designed to get the results it currently gets. Don Berwick, who's a big guru in quality and safety, talks about us all working in health and having improvement knowledge and skills. And our knowledge to action framework really describes the knowledge and actions that we would like to see everybody working in health having. And this is everyone from frontline all the way through to the board. And we describe these. Our clinical governance framework gives us a structure for thinking about the quality and safety. And this covers, again, responsibilities for everybody working in health, again, all the way through to the board. And we see this clinical governance is being delivered by consumers, people working in health, as well as managers, all coming together to improve the quality and safety and the experience of care. So when we're thinking about improvement, we also need to think about the system that we work in. And often when you start working in an organization, we see something on the left in the top line that people show you an organizational chart, thinking that this is how we can describe the system. But the more you work in it, you realize it becomes like the lower layers, that messiness. And actually health is a really complex adaptive system. It is composed of lots of people working in many relationships, many agencies, all trying to deliver care. So sometimes we need to think about things as to whether they're simple, complicated, or complex, and you can see that on the right-hand side. Simple things such as hand washing are easy. We can put in a protocol and it's linear, so that we wash our hands, we know that we'll reduce infections, and COVID-19 has recently shown us that. When we work in other areas of quality and safety, and especially when we're trying to improve outcomes of healthcare, we're really working in the complex area, and that requires a bit of a different approach. I encourage you to have a look at something called the Conniving model that David Snowden talks about. And this is really looking at complexity and how we need to approach that. Our human brains like us to try and simplify things and make it easier to understand. But when we think in that way, we sometimes don't come up with solutions that really address complex problems. And that's what this quote is about, that often we think there's a very simple solution to a complex system, but actually that's the wrong approach. So when we're working in complexity, we need to think about the system, we nudge it and we look at the responses. And that's different than the simple or complicated domain, where it's much easier to see those linear progressions. So when we're thinking about health and thinking about improving the system and learning from the system, we need to think about complexity. And we actually need to also have a large number of people around the table to bring in lots of different lenses and different approaches. And the one thing to remember is that no one person will have all the answers. And that's why we need to sit down with a team and look at things from different angles, and look at it from our different professional groups. And importantly as well, bring consumers in, because they can have a very different lens in the system. And that's that diversity, bringing together a collective sense making. And that's really part of working in health. We don't work alone, we work in teams. This is our National Adverse Events Reporting Policy, and this is really to try and bring some national approaches to how we support and review and learn from events that perhaps haven't gone quite as well. The 6 principles that we look at in this report are really those of open communication, involving consumers in their whānau, making sure that we review things in culturally appropriate ways, and that we focus on the system and try and ensure that the changes we're making are those of the system. And we want to encourage a safe reporting culture. So that really gives you a very quick introduction to the Health Quality and Safety Commission, and I really encourage you to go and visit our website. And if you've got any questions, you can always email us at the information email, and we'll get someone to respond to you. So thank you very much for your time today, and I'm going to finish off with a little closing. Apiti hono, tatai hono, ratau te hunga mati kia ratau, tato te hunga ora kia tato, tēnā koutou, tēnā tato katoa.